Hi everyone, this is Elizabeth Reed with the Network of Behavioral Health Providers in Houston. We are very pleased to welcome you to this webinar on the 2015 Physician Quality Reporting System, or PQRS, for behavioral health providers. The Behavioral Health Affordable Care Act initiative in Houston has invited Molly McHarris to provide this presentation for us and to answer our questions specifically about PQRS for behavioral health providers. And I believe we also have Dan Green from CMS will be joining as well. And Molly, are you there?
Yes, I'm here. Thank you for having me today.
Hi, Molly. Thanks so much for being with us. We will have an hour for Ms. McHarris's presentation and then 30 minutes for question and answer. Molly, can I turn it over to you?
Yes, that would be great. Thank you. Thank you again very much for inviting me here today. I have a lot of information to share with you guys. Hopefully this will be beneficial. If you guys have questions at the end, I'll take as many as I can. If I'm not able to answer all of your questions, I'll work with Elizabeth and the behavioral health team for her to share them with me, and we can get you guys answers. So let's go ahead and get started. I think if we can go to slide 3, please. So the agenda for what I will be covering today. So I'm going to start with a basic overview of what PQRS is. Many of you are already participating in PQRS and know what it is, but the more that we speak with people out in the field, there seems to still be a pretty basic misunderstanding of exactly what PQRS is and its purpose. So I'm going to talk a little bit about that, and then also the options for selecting PQRS measures. Then I will also be going over reporting for behavioral health measures, and then also some resources. So to start off with, what is PQRS? So PQRS is, of course, a reporting program that promotes reporting of quality information by eligible professionals. It's been around for many, many years. It actually began back in 2007. At that time, it was referred to as PQRI, the Physician Quality Reporting Initiative. It was modified to the Physician Quality Reporting System, I believe, back in 2011 or 2012. So PQRS, it began with a series of incentive payments that were issued, and it has now since moved to a negative payment adjustment scenario, whereby if you are not reporting under PQRS. So as you can tell on the slide, we are now in the payment adjustment situation for PQRS, where there are a series of negative payment adjustments that you would receive if you are not considered a satisfactory reporter. The reporting period is 2 years prior to when the actual payment adjustment would hit. So for example, the 2015 PQRS payment adjustment period is based off of reporting that happened in 2013. The 2016 PQRS payment adjustment period is based off of reporting that happened last year in 2014. And the 2017 PQRS payment adjustment period is based off of reporting that will be happening this year. Moving forward, it is a 2% negative payment adjustment, and you would have to meet that based off of your meeting annual requirements. So it's an annual activity that you would need to do to participate in PQRS. And thank you, Elizabeth, for muting all the lines. Hopefully everyone can hear me much better now. So thank you, and we can go ahead and move on to the next slide. So why is PQRS important? We get asked this question all the time. We hear constantly from providers that they feel that they do quality within their own offices. They shouldn't have to participate in PQRS. And so some of the things that we have found since we've implemented the PQRS program is that it really does give the eligible professionals the opportunity to assess the quality of care they're providing to their patients. We've heard in the past where providers, they felt that they were giving really great quality of care, but until they actually started measuring it and tracking it, they were able to determine that, oh, there actually were, you know, a whole handful of patients that were inadvertently missed. So they can identify that also based off of the feedback reports that we provide, and then also depending upon the way that you report your data into CMS, if you use a registry or a qualified clinical data registry or an EHR, they also provide you feedback reports so you can better quantify that. Next slide. So who can participate? So as you can see on this slide here, we do have 3 different main buckets of people who can participate in PQRS. The Medicare definition of physician, which includes the MDs, the DOs, etc. We also have the practitioners and therapists. Please note that the PQRS definition of an eligible professional is not the same across other CMS quality reporting programs. The Medicare EHR incentive program, they have a narrower definition of an eligible professional, and the value-based payment modifier, they also use the term eligible professional. Currently, their program is only applying to Medicare physicians. So we realize that this can be confusing, that the same terminology is used across 3 programs and it is defined differently. That is something over here at the CMS as a whole we are working to try to modify as much as we can. Unfortunately, some of the limitations are defined by our authorizing statute, the actual law that authorized our program, but as much as we can have the same definition of an eligible professional across the 3 programs, we are trying to do that since we know there is confusion. Next slide. So how to participate in PQRS? There's essentially 2 main ways, and then under these 2 main ways, there are various options on how you can get the data in. The first is as an individual, and that is based off of your unique TIN or tax identification number and your unique rendering or individual NPI, your national provider identifier. If you participate as an individual, no sign up, no registration is required. You would just need to select the quality measures you want to report on, figure out which is the best reporting method for you, and start reporting. Alternatively, you could report as a PQRS group practice through the group practice reporting option, or GPRO. If you choose to participate as a GPRO, you have to register. The registration period is it started on April 1st, so it's open now, and it runs through June 30th. To be a PQRS group practice, you would have to have 2 or more NPIs associated with your TIN. And one thing I also want to clarify about being a PQRS group practice is that just because your particular organization, the place that you work, you are a quote-unquote practice, that does not mean that you have to be a PQRS group practice. We have many large practices who participate in PQRS as individuals. It's just a different way to participate. So just wanted to try to make that as clear as possible. Additionally, eligible professionals who participate under other programs, such as the Accountable Care Organization projects, either the Medicare Shared Savings Program, ACO, the Pioneer ACO, or the CPC initiative, the Comprehensive Primary Care. When they participate in those programs, they also get credit for PQRS. Next slide, please. Okay, and next slide again. So from here, I will be talking about ways to select your PQRS measures. So some of the factors that you should take into consideration when picking which measures you want to select for PQRS reporting. We have a very large set of PQRS measures available. We have around 270 measures, I believe. That's because, as you could tell from the list of eligible professionals who can participate under PQRS, there are many, many specialties out there. and we still hear from many specialties that there aren't sufficient measures for them to select. We work very closely with the specialty societies and the measure developers for all of the various specialties to encourage them to develop measures which are applicable to their specialty. So just wanted to make you guys aware that we do continuously work with the specialty societies and measure developers to try and get more measures in our program that are relevant to them. So some of the things you want to consider when selecting your measures are the clinical conditions you usually treat, the settings where the care is delivered, and then the quality action. These are all specced out within the measure specification, so you would want to make sure that you select a measure that would commonly apply to you. Next slide. Just a couple other considerations you should think of when you're selecting your measures. Again, the clinical conditions you usually treat, the type of care that's provided, the settings, and then if you have any other quality improvement goals for the given year, if you have goals that you've either set for your practice on your own or through other payers, there are quality improvement goals. Many of the measures that we have are available through other quality programs that are not as part of Medicare. So that's something you can take into consideration, as well as other quality reporting programs. There are a lot of state-run programs where they could be using very similar quality measures to what we have in PQRS. Next slide. So reporting on PQRS. So again, as I mentioned previously, the two main ways to participate are either as an individual or as part of a group practice. I also mentioned that there are various ways under those two options, and you can get the data into us. That is what we would call a reporting mechanism, and I will be talking about that a little bit later. So I won't cover that quite here yet, but more information to come on that. Also, and this will be covered at the end of the slide deck, our resources. Our PQRS implementation guide goes over the decision trees, which talk about all the various options we have available under PQRS. Next slide. Okay, so individual participation. So as I mentioned previously, if you want to participate in PQRS as an individual, you do not need to register. You would only need to register if you want to be a PQRS group practice. So the options we have available for individuals participating in PQRS are the electronic health record or EHR reporting mechanism. We do use EHR that has been certified by the Office of the National Coordinator, ONC or ONC. The EHR would have to be considered CERT or Certified EHR Technology. Under our EHR option, there are two main ways and you can get the data into us. The first is where you or your practice manager would submit the data on your behalf directly to CMS. And then the second would be where your EHR vendor would be submitting it as a data submission vendor. Okay, the next option would be reporting via claims, our claims-based reporting option. I do want to call out that this is not the same as the administrative claims option we had available under PQRS during the 2013 year. That was only available during that 1 year. It is not an option we currently have available anymore. The claims-based reporting option that I'm referencing here is the option we've had available under PQRS since 2007. It is where you, the provider, or again your billing manager, would take an action by appending a quality data code, a QDC, or a G code to a claim. And they would do that on a denominator-eligible claim on the specific line item for the patient that met that denominator-eligible instance, and the QDC code would let us know what quality action was performed, whether performance met happened or if there is performance not met or performance exclusion. The claims-based option is also only available for individual reporting. The next option is reporting via a qualified PQRS registry. Reporting as a qualified PQRS or through a qualified PQRS registry has been available since 2008. PQRS registries are entities that they essentially work as third parties between the providers and CMS. So the way that would work is the providers, you guys would enter into an appropriate business relationship with the registry, and the registry would submit your PQRS quality measures data on your behalf to CMS. The qualified PQRS registry option is available both for individual reporters and group practice reporters. And then the last individual option we have available is reporting via a QCDR or qualified clinical data registry. Before I explain this option, I do want to comment, we do realize that the qualified PQRS registry and the qualified clinical data registry, the terms are very similar. We are aware of that. Unfortunately, due to the way that the language was used within our statutory authority, when it became law, we have to use those terms. So it is something that we are aware of, and we are aware that it does create some confusion for the stakeholders out there, for you all, on what is the difference between a qualified registry and a QCDR. But unfortunately, just due to the language that was written in the law, we have to use these terms as they have been used to date, as either a qualified registry or a qualified clinical data registry. So the Qualified Clinical Data Registry, or QCDR, this is a relatively new reporting mechanism. It began back in 2014. And the QCDRs, they, you can think of them as qualified registries that have more things to them. The QCDRs, they work similar to a qualified registry, that they are working as a third-party vendor to submit data on your behalf to CMS, but QCDRs, they are what you would typically think of when you would normally think of a registry. They are registries that have been in existence for many, many years oftentimes. They are performing quality improvement activities or fostering quality improvement. And one of the additional things that QCDRs can do is they can report on a set of non-PQRS measures. So QCDRs can report, they can offer to their providers any of the measures that are within the PQRS measure set, the 250 some odd measures we have available. They can also offer up to 30 non-PQRS measures to their eligible professionals. And these are oftentimes more advanced types of measures, outcomes-based measures or risk-adjusted measures. And since it is a new option, we are still working with the QCDRs to improve this as we move forward. So that covers all the individual participation options. Next slide. Okay, the group practice reporting option. So as I mentioned previously, the registration will be held from now until June 30th. The specific link you would need to go to register is on the slide here. When you would register as a group practice, there are a couple things that you would need to do. You would need to select a group size, and that is determined by the group's PACOS information. Under PQRS, there are 3 PQRS group sizes: the large groups, 100 or above, the medium-sized groups, the 25 to 99, and then the small groups, the 2 to 24. Next slide. Okay, one of the new requirements we have in PQRS under 2015 is the requirement to report on a cross-cutting measure. This is available for specific reporting mechanisms under PQRS, either the claims-based reporting mechanism or the registry-based reporting mechanism. And This is for those eligible professionals who have a face-to-face visit with a Medicare patient. If you have a face-to-face visit with a Medicare patient, you would need to report on a cross-cutting measure. And the cross-cutting measure, there are about 18 to 19 measures, and they are from a common set of measures that are commonly applicable to providers. Some of the measures in there are medication reconciliation, tobacco cessation, depression screening, etc. So we do feel that eligible professionals that are having face-to-face encounters with Medicare patients, that this is something that they can report on, and then often, many times, it's something that you are already reporting on. So it would just be something new that you would need to track. Next slide. So how do we calculate PQRS measures? There's a reporting rate and also a performance rate. The reporting rate is where you would take the entire numerator and divide it by the denominator. The denominator is the entire eligible patient population. The numerator for reporting rate would include both all of the performance met instances and the performance not met instances. The performance rate is taking the denominator, but at that point we're only looking at the performance met, so where you actually did the quality action. Next slide. Okay, so this slide provides a brief overview of the different payment adjustments that are currently impacting Medicare providers. This just provides a brief overview of that. So PQRS, as I've been talking about for most of the presentation, affects all eligible professionals. It's a 2% reduction. The Medicare EHR incentive program or meaningful use, that would be a 3% reduction. That is only applicable to the Medicare definition of a physician. And then the value-based payment modifier, that would apply to, again, the Medicare definition of a physician, and that is for all physicians, both solo practitioners and groups with 2 or more providers. Depending upon your group size and whether or not you are a PQRS reporter, there would be a different amount of payment at risk. It could be anywhere from a negative 4% to a positive 4%. You will also notice under the value modifier, they reference an X factor. And the X factor is due to the value-based payment modifier is required by law to be a budget-neutral program. So what they do is they take a look at the entire population of providers and where they fit on the various scale on whether or not they are high quality, low cost, low quality, high cost, and determine the total amount of payment that would be reduced. And then that fluctuates on what the total X factor would be for the providers that are in the high quality, low cost tier. Next slide. And next slide again. So some ways to report behavioral health measures. And I apologize, I can't see this in too much detail, so but I understand that all of you have the slide there. So what we have on this particular slide is a copy of our CMS 1500 claim form, and we provided information on the way that you would report via claims, so the claims-based reporting mechanism. This is still one of the ways that the majority of providers do report, even though we are encouraging people to move to more electronic-based reporting mechanisms. Some of the important things to note would be where you would place your TIN, your NPI, your rendering provider ID. That is really important when you're reporting via claims, and that also you would append the correct quality data code as well as the correct CPT codes, ICD-10 or ICD-9 codes, depending upon the timing, to the claim. Next slide. So more information on the claims-based reporting. So some of the first steps you would want to do is identify the eligible cases. So when you are selecting your quality measures, you would want to determine your quality measures that you would want to report on, and within the specific quality measure specifications, there is a denominator statement, and they specifically call out who would be eligible for the quality measure. So you would want to take a look at all of the specific codes that are called out in the denominator section and look at your specific billing software, EHR software, and determine whether or not you want to or need to put edits within your software to make sure that no patients are missed. From there, for meeting the claims reporting criteria, the claims reporting criteria for PQRS, again, this option is only available if you're participating in PQRS as an individual reporter, is that you would be reporting on 9 measures covering 3 national quality strategy domains. The national quality strategy was issued a few years back, and it provided 6 domains of care. From that national quality strategy, CMS has issued a quality strategy. And what we have done under all of the quality reporting programs over here at CMS is we have grouped the specific quality measures into one of the 6 national quality strategy domains. So that is where the national quality strategy domain requirement comes from under PQRS. So you would need to report 9 measures covering at least 3 of them. It doesn't necessarily have to be 3 measures in each national quality strategy domain, but you would need to have 9 across 3, and that would be for at least 50% of your Medicare Part B physician fee scheduled patients. Additionally, if you have one face-to-face encounter with a Medicare patient, you would also be required to report on one of the cross-cutting measures. So then the next question that we typically get is, well, I don't have 9 measures covering 3 domains. What am I supposed to do? So if you don't have 9 measures covering 3 national quality strategy domains, you would want to report on as many measures as you have patients that are eligible for, covering as many national quality strategy domains. What would happen is you would get subject to our MAV process, our Measure Applicability Validation process. So if you determine from looking across our quality measures that you only have 5 measures that cover 2 national quality strategy domains, then you would need to report on those 5 measures covering the 2 national quality strategy domains. Let's also say that you have a face-to-face encounter with a patient. So of those 5 measures, at least one of those 5 measures would need to be one of our cross-cutting measures. So if people have more questions on that later on, I'd be more than happy to explain that in more detail. But if at any point you don't have 9 measures that you can report on, you would automatically fall subject to our MAV process. And again, what MAV does is it looks across all of the claims that you reported for the year to determine were there any other patients that you could have reported on based on the claims that you do report and the clinical clusters that we have within MAV. The clinical clusters they include closely related measures, and the concept is that if you report on one of the measures that is within one of the clinical clusters, that you could have reported on other measures within that same cluster. The other thing to note about the claims-based reporting criteria is that measures with a 0% performance rate will not be counted. Next slide. Okay, so use of the CPT Category 1 modifiers. So many of the PQRS measure specifications include specific instructions on how to use the CPT Category 1 modifiers. The CPT Category 1 modifiers may be reported with or without the modifiers. You do want to look at the specific measure specs to fully understand whether or not you can report those. Also, please note that surgical procedures billed by an assistant surgeon would potentially be excluded from the denominator population, so their performance rate will not be negatively impacted for PQRS. There also is some information on the slide here talking about certain surgical modifiers that we exclude. And the last bullet talks about additional information for surgeons on modifiers that we would exclude. Next slide. More information related to CPT codes, the CPT Category 2 codes. The CPT Category 2 codes have 5 alphanumeric characters that end with a letter F. The CPT codes are not modified or updated during our reporting period. They are valid for the entire year, and they describe a clinical action that's part of the measure numerator. So again, you would want to look at the specific measure specifications to make sure that you are using the correct CPT codes. The quality data codes are non-payable HCPCS codes that are comprised of either the CPT Category 2 codes and or G codes that help describe the clinical action. Sometimes the clinical action could apply to more than one condition and therefore more than one measure. We have tried to eliminate as much as possible quality data codes that cover more than one measure. So again, just please make sure that you take a specific look at the quality measures you would want to be reporting to make sure that you are using the correct quality data codes, CPT codes. They have changed over previous years, so you just want to make sure that you are using the most up-to-date specifications and that you're using the most up-to-date codes, again, if you're reporting via claims. Next slide. Okay, more information related to the performance measure exclusion modifier categories. There's typically a 1P, a 2P, or a 3P. The 1P is typically related for medical reasons. The 2P is typically related to patient reasons, and the 3P would be for system reasons. And information is available on what they would be. Again, it is specific to the quality measure itself, but these are examples of what the typical 1P, 2P, or 3P would be. Next slide. Okay, so more information on claims-based reporting principles. So up to 4 diagnoses can be reported in the header on the CMS 1500 claim form for the paper claim, up to 12 on the electronic claim form. Only 1 diagnosis can be linked to each line item, although for PQRS, all of the diagnosis codes will be taken into consideration for analysis. We use all data, or we use all diagnoses from the base claim and service codes for each individual eligible professional for our PQRS analysis. Again, we do strongly encourage eligible professionals to review all diagnoses and encounter codes listed on the claim to make sure that you're capturing all the respective information. You cannot resubmit a claim to Medicare just for appending a quality data code or a G code. So it is important that if you are reporting via claim, that you take a double, triple look at the claim before you send it in, just to make sure that you haven't missed any information. All diagnoses reported on the base claim will be included in the PQRS analysis, as some measures require reporting more than 1 diagnosis on a claim. So for line items containing a QDC, only 1 diagnosis from the base claim should be referenced in the diagnosis pointer field. To report a quality data code for a measure that requires reporting of multiple diagnoses, enter the reference number in the diagnoses pointer field that corresponds to one of the measured diagnoses listed on the base claim. Regardless of the reference number in the diagnoses pointer field, all diagnoses on the claims are considered in the PQRS analysis. Next slide. If your billing software limits the number of line items you can have on a claim, we do encourage you to add a nominal amount, such as a penny, to one of the line items on that second claim. If you do send in a 1 cent claim, you would get back in your remittance advice that 1 cent has been denied by Medicare, but it is the way to go ahead and get those quality data codes into us here so they can be processed. We do also have the ability to subsequently join the claims based on the same beneficiary for the same date of service or the same TIN MPI. Again, we also do encourage you to work with either your billing software, or your clearinghouse, or your EHR vendor to make sure that if you do choose to report via claims-based reporting, that there aren't any unforeseen complications that are limiting the ability for the data to make it into CMS. We have heard, not so much as of late, but years and years ago, that vendors or clearinghouses were inadvertently stripping some of the PQRS codes out. So we do just encourage you to work with your software vendor to make sure that doesn't happen. Next slide. More reporting of QDCs via claims. So again, the QDC would need to be reported on the claim with the denominator billing code for the specific beneficiary, for the specific date of service that you saw the beneficiary, and by the eligible professional that provided the covered service. Next slide. So again, you would need to submit the specific QDC information on a 1 penny line item. The claim with the penny would be rejected, but as I mentioned previously, the QDC associated with the quality action. And again, solo practitioners would need to follow their normal billing practice of placing their NPI in the billing provider field. Next slide. Okay, submitting claims through your MACs. So the QDCs would be submitted to MACs either electronic-based or paper-based. Next slide. There's 2 options. There's either the group NPI or the solo NPI submission. Again, if you're doing the group NPI, it's important that you also reference the individual rendering NPI in the specific spot on the claim. If you are reporting as a solo practitioner, you would need to follow your normal billing practice. Next slide. Okay, so some of the CARC and RARC codes you might receive. So the CARC stands for the Claims Adjustment Reason Code, and the RARC is the Remittance Advice Remark Code. The CARC that you would typically receive is CARC 246 with RARC N620. The CARC 246 receives that this non-payable code is for required reporting only. So the CO 246 N620 is what you would see on the explanation of benefits. Next slide. Okay, so now I will start talking about some of the other reporting options. And for those of you that are watching the clock, I should be able to make it through the rest of these slides in the next 15 minutes to leave plenty of time for questions. I know this is a lot of information that we're covering today, so I do want to make sure to leave time for questions for those of you who have them. So reporting via qualified registry, this is available, again, if you are reporting as either an individual eligible professional or as part of a PQRS group practice. The reporting criteria is 9 measures covering 3 national quality strategy domains for at least 50% of your Medicare Part B fee-for-service patients. Registry reporting also has MAV in place. Again, the MAV process is our measure applicability validation process, and that is where if you don't have 9 measures you can report on, you would report less than 9 measures. You would report rather on as many measures as you have available that cover as many measures and as many domains. Also for registry-based reporting, we do have our cross-cutting measure requirements that if you have a face-to-face encounter with the patient. And lastly, we also have a requirement that if you have any measures with a 0% performance rate, they will not be counted. Next slide. Okay, so our other option that we have available for reporting via qualified registry, and that is reporting via a measure group. This is only available if you are reporting as an individual, so this would not apply if you are reporting as a PQRS group practice. So if you register to be a PQRS group practice, you cannot report via measure groups. If you want to report using a measure group, do not register to be a PQRS group practice. You would just need to work with your registry and say that you want to report via a measure group. So the way that measure group reporting works is a measure group has 6 or more quality measures, and typically the denominators are aligned on the measure group. So you would report on the same set of patients. We've tried to do that as much as possible. There are some measure groups where the denominators, either the age range of the patient or some of the denominator codes are somewhat different. But typically it's where it's related to a clinical condition such as heart failure or coronary artery disease, diabetes, etc., where you could report all of the 6 measures on a patient. You would need to report on the measure group for at least 20 patients, the majority of which must be Medicare, so at least 11 of those patients must be Medicare. If you choose to report via a measure group, we strongly encourage you to report on more than 20 patients. We have had instances in the past where people miss this requirement by 1 patient. We do not want that to happen to anyone. So if you are reporting via measure group, please ensure that you oversample a little bit. Go ahead and try to report on maybe 25, 30 patients. And again, 11 of those would need to be Medicare. Next slide. Okay, so reporting via EHR, as I mentioned previously, our EHR option do use certified EHR technology. This is available for both individual EPs and group practices. The criteria is reporting on 9 measures covering 3 national quality strategy domains. You'll notice there is not a patient threshold here. Rather, you would report on 100% of your patients. However, since you're using your EHR, this would all be built into your certified EHR technology, so there shouldn't really be any additional action that you would need to do within your EHR beyond reporting on the quality measures. If for one reason your EHR does not have enough patient data for 9 measures covering 3 national quality strategy domains, you would just report on as many measures and as many domains as you have available. The EHR reporting option is for both Medicare and non-Medicare payers. The caveat is since PQRS is a Medicare program, at least one of those patients would have to be Medicare. Next slide. The eCQMs for 2015 e-reporting, you would need to use the July 2014 version of the eCQMs. As with all measures under PQRS, there are annual updates that are made to the measure sets. You just want to make sure you are referencing the most up-to-date measure specifications. Next slide. Okay, so more information related to the MAV process. So again, this is a process that's in place if you are reporting either via claims or registry reporting. and that is where you have less than 9 measures or less than 3 domains. So as I mentioned, it will look across the rest of the measures that you could have reported on to determine if there are more measures you could have reported on. It also does take into consideration whether or not you could have reported on the cross-cutting measures. So if, for example, you report 9 measures covering 3 domains and you had face-to-face visits with a patient and you had face-to-face visits with a Medicare patient and you did not report on the cross-cutting measures, you would fail MAV. So it is important that you do report on the cross-cutting measures if you are having face-to-face visits with a Medicare patient. Next slide. MAV would also apply for certain measures. We do have in place our 0% performance rules for measures that are inverse measures, where a 100% performance would actually be considered low quality, then the performance rate would need to be less than 100%. MAV, it can be a somewhat confusing topic, so again, more than happy to take questions here in a little bit. Or if you have more questions related to MAV, you can click on the link on the slide here. We do have a lot of educational materials out there that can go over MAV in more detail as well. Next slide. Okay, so some of the behavioral health measures reporting options. So 5 PQRS measures are reportable via EHR only. They're listed on the slide here. 3 measures are reportable via claims and registry only. Additionally, there are 2 measures that are reportable via registry only. Next slide. So the behavioral health measures listed by domain, you can see that there are measures that cover the effective clinical care domain, the communication and care coordination domain, and the community and population health domain. We also have listed out here the NQF number, the PQRS number, and the reporting method there available. Next slide. And more measures, which I think you guys all have a copy of the slide, so I won't go over these. Next slide. Okay, and resources and where to call for help. So I'll just go over this really quickly, and then we can do the Q&A, just because there are some resources I do want to call out to you. So next slide, please. So slide 42, this has all of our information related to our website and some of our commonly referenced documents. If you haven't had a chance to look at these, we do encourage you to look at them. I realize that there's a lot of information out there and it can be sometimes difficult to filter through it, but the information that's listed here, these are some of our go-tos that we commonly refer people to if you're just getting started. Next slide. And the information on these slides here are more related to our EHR options, our registry options, and our MAV process. Next slide. And where to call for help. So again, I will be taking questions here in just a minute, but if there are questions that for one reason or another we couldn't get to today, you can always contact the QualityNet Help Desk. They're available Monday through Friday from 7 to 7 Central Standard Time. They can answer any question related to PQRS. If you have questions related to your payment status, you would need to contact the Provider Contact Center. Additionally, if you have questions related to the EHR Incentive Program, you would want to contact the EHR Incentive Program Information Center. If you have questions related to the Value-Based Payment Modifier, you would want to contact their help desk. And if you have questions related to physician compare reporting, their help desk is available at that email. So I think I can go ahead and conclude the presentation here. The rest of the slides are just more information and resources. So Elizabeth, I think I'll turn it back to you so we can start the Q&A period.
Okay, this is Lauren at MHA. We're getting people together. We're working on getting things unmuted without getting that wonderful feedback that we had before. So just give us a few seconds and we'll get ready to go.
Hi, can you guys hear us? This is Elizabeth in the other office. And we have a group here watching the webinar together, and we've been thinking of some questions. Molly, can you hear me?
Yes, I can hear you.
Great. Okay, well, we have a first question from Nagdila.
Okay, my question is, we're trying to figure out how we would record
I can't hear anything.
Our PQRS measures, either as a group or as individual providers. We are an outpatient behavioral health practice, and we're trying to figure out which one applies, whether we report as individual EPs or as a group.
Okay, great. So one of the things that I would do first is take a look at the quality measures that would potentially apply to you. So if you look at the slides a couple slides ago that I had just gone over where we specifically called out the behavioral health measures that commonly apply to folks, I would take a look at those measures and then look at the reporting mechanisms that are available via, and then you would want to figure out what options make the most sense for you. One of the advantages of reporting as an individual is if you are part of a multi-specialty practice. Let's say for one reason or another it's a practice of 10 providers, 5 are general internists and 5 are behavioral health. And it may be that the 5 general internists want to report on measures that are specifically relevant to them and their patients that they see, and the 5 behavioral health would, of course, want to report on measures that are specific to them and the patients that they see. So in that scenario, they probably wouldn't want to select group practice reporting because you would have to include everyone under that practice. They would have to report on a common set of metrics. So, but on an alternate scenario, let's say it's a practice of 10 providers where all 10 are behavioral health, and they determine that the 5 measures they want to report on are available via Registry, for example, and I'm making this up, and they want to report group practice Registry. Then they should register and report that way. So it really will make a difference based off of your practice and the measures you want to report on. I hope that helps to answer that.
Yes, it did. Thank you.
We have another question.
All right, so in order to be able to qualify for the reimbursement, we have to report on 9 measures. And so each of the individual 9 measures, they must apply to 50% of the Medicare population that we see. Is that correct?
That's correct if you're reporting via claims reporting or registry reporting.
And Molly, is that for EPs or for group practice?
It would apply for both. So again, just remember, claims reporting is only available if you're participating as an individual, but for conversation's sake, let's say you're reporting via registry. So it's the same criteria. You would do 9 measures covering 3 domains for 50% of your Medicare patients, and that would be whether or not you're doing it on your own as an individual or if you're doing it as part of a group. The thing to keep in mind is that if you're doing it as part of a group, it would be 50% of the entire group patients. So again, my scenario where it was one group, and when I say group, I mean one TIN, one tax identification number, and when I say 10 docs, I mean 10 NPIs. So you would look across that 110, all 10 of those NPI charges they billed to Medicare, and for 50% of them, they would need to report on the PQRS measures.
Got it. Okay, I have one more question too. So, never mind, it applies to claims-based reporting, and I don't think that we would be using claims-based reporting. But I'll ask it anyway. Okay. So, so let's assume that we are billing, or we're going to do individual, and we're doing claims-based reporting. So when I file a claim for a service, so say I'm a psychiatrist and I'm billing an E&M code, on that same claim form, I also bill my quality codes?
Yes, you would want to make sure that you are billing that on the claim that has the actual date of service for the patient that is eligible for the measure, with all their diagnoses codes, the charges and everything. You would want to make sure that on a specific line item, you bill the appropriate quality data code. And it's important that you do it on that specific claim form, because if you miss that instance, it would be considered a missed reporting instance. And, you know, we have our 50% reporting threshold, so you would only really need to hit 50% of your patients, but you know, you don't really want to lose track of too many of the patients, because that 50% threshold could creep up on you. So you do want to make sure that when it is the actual service, the claim form that the patient fell into the measure for, that you're also billing the quality data code, or reporting the quality data code, rather.
Sorry, Molly, can you hear me?
Oh. Yes, please go ahead, Dan. Thank you.
Yeah, and this is Dan Green from CMS also. Just to be clear, you cannot resubmit a claim form solely for the to add a quality data code. So if your claim were messed up for some other reason and you had to file the claim, you could append the quality data code then. But you know, if you forget to put one on, you can't refile the claim just to add it.
Okay, I have a question here from Carol. Her question is we are an FQHC and bill Medicare Part A as a facility. Does PQRS apply here, since we do not bill Medicare Part B?
Sure. So PQRS would not apply to the services or charges that would be billed for the federally qualified health center. However, and this is where it becomes more confusing than we would like it to be. In many instances, in reality, a provider may work at an FQHC, and then they also may work at a non-FQHC. They may have a separate practice. And in those instances, that provider who is working under some of his, let's say, 80% of the time at the FQHC and 20% of the time he's moonlighting somewhere else, he would still need to participate in PQRS. But PQRS is a purely Part B program, so if you are only doing Part A at the facility level, then no, you would not need to participate in PQRS. But it's really the scenario where it's a provider who is working at an FQHC. Their services that they render under Part A at the FQHC are not eligible for PQRS. However, the services they render under the Part B physician fee schedule are eligible for PQRS. So I hope that helps.
It doesn't.
Yes, it does. Thank you.
Molly, I have a quick question. Are the penalties for not successfully participating in PQRS expected to go up? Is anything published? You know, do you expect that percentage to go up over time?
Sure. So under PQRS, the legislation says that it will be 2% annually. So if the law changes, it could go up. We've had a lot of laws that have passed over the years that have impacted PQRS, but as it's currently scoped, it would be a 2% reduction that could potentially impact providers every year. Again, they would need to meet the reporting requirements every year. If they were good in 1 year, it does not carry over to the next year. So it is an annual requirement they must meet. The one thing I do want to call out, though, is that that's specific for PQRS. The value-based payment modifier, they do have the ability to either increase or decrease the amount of payment that could be at risk for their eligible professional population. So that has the ability to be modified over time. But for PQRS specifically, no, it's 2% until the law changes.
Thank you. And if I have a second question about the value-based payment modifier, which is on slide 17, I just want to clarify that list applicable to eligible providers, and we use that term sort of interchangeably to mean a lot of different things. And I want to confirm whether the value-based payment modifier applies to behavioral health eligible providers such as psychologists and LCSWs.
So it would apply to the Medicare definition of physician. So it applies to physicians only. So it would apply to MDs.
Great. So it's not something the rest of us have to worry about.
One thing I will say, though, is please keep your eyes open for potential changes to that program. They did have some language in their rule last year. They were potentially looking at expanding it to other healthcare professionals that would potentially impact people beyond the MDs. As of right now, it's only for the physicians, but that could change. But as of today, it's only physicians.
Okay, one technical question on the group practice participation. So in 2014, we went on and tried to register through the PQRS registration system, and you have to submit something and then it's supposed to email you back. We never got anything back. Now, we weren't set up to report in the year, so we didn't really follow up on that. But do you know why we would not have received information back? Is it tied to one particular individual in the practice?
So it would be tied to the specific individual who signed up on behalf of the group practice. So to actually register to be a group practice, and we actually, CMS, we're holding a national provider call next Thursday afternoon on how to register to be a group practice. So if anyone is actually looking into that option, I would strongly encourage you to attend that call. The one thing I would say is you need to register for that call a day ahead of time. I think you have to get it done by Wednesday morning. But just if you are looking to become a group practice, please register for that call and listen in next Thursday if you can. But to answer the question, so the email would have gone to whomever received the IX account and actually registered on behalf of the group. Since it sounds like they're talking about a specific instance, I would actually recommend that the inquirer reach out to, it's the VM help desk, so it's the fourth bullet on the slide we're currently looking at, slide 44. And if you give them your information, they can describe to you in specific detail on why you didn't receive that email. It could have been that either your registration wasn't complete or there are other factors that could have occurred, but they could give you the specific details on why you didn't receive those emails.
Thank you.
Lauren, are we getting any questions in the chat box that we would like to respond to?
No, there haven't been any further questions over here.
Okay, we have some more in the room then.
Hello, thank you very much. This is Alejandra with MHA, and I have a more general question. I'm looking on slides 38 through 40 at the list of behavioral health measures, and specifically at the reporting methods. And I'm curious as to why certain measures can only be reported via certain methods, and if you anticipate any broadening of that so that more measures can be reported via a greater variety of methods.
Sure. So I'll take a stab at that one, and then Dan, if you're still on, if you want to weigh in as well. So it's related to why we have some measures that are only reportable via specific methods. So generally speaking, over the past few years, we have started to reduce the number of measures that are reportable via our claims-based reporting mechanism. The agency as a whole, we are moving towards more electronic-based methods of getting data in. So we have started decreasing the number of measures that are available via our claims-based reporting mechanism. So you will typically see that the largest number of measures that are available, the broadest set, is in our registry-based measure set. So we typically have really as many measures as we can available through the registry-based measure set. Some measures that are specific to either the EHR reporting or the web interface-based reporting option are because they're spec'd out in that fashion. They're developed specifically for that reporting mechanism. And the other thing is that it also really depends on the measure owner and the measure developer on how they develop the measure. But Dan, I don't know if you want to add anything to that.
No, I think that was a great answer, Mel, but the only other thing I would add is, as Molly said, we're trying to encourage more electronic submission and move more toward registry and EHR reporting. Additionally, we feel that in many instances we can get better information from an EHR or via a registry because it's not tied, the information is not tied directly to, okay, I saw the patient today and I did X, Y, or Z. I know this doesn't apply to you guys, but for example, if you saw a woman today and you ordered a mammogram, well, you couldn't really say that she had the mammogram today. She's going to get it in 2 weeks. But with a registry, you could submit that information at the end of the month. People are not going to hold on to claims indefinitely to report quality data.
Thank you. Just a really quick follow-up question, because that makes a lot of sense, that move towards the more electronic reporting. So could we anticipate that more measures will be reportable via EHR? For example, some of those that right now are via claims or registry will add EHR to their reportable mechanisms?
That's likely. We are, looking at measures. Measures are being electronically specified. I would think that probably will not happen, however, until the next iteration of meaningful use, but that's a guess.
Thank you.
Are there any people on the call that are able to join by voice or any extra chat session questions? We have some more in here, but we want to definitely, make the conversation available to other questions. In that case, I'm interested to know a little bit about the measure selection process, and have there been open comment periods, and particularly any evidence behind why these measures are selected? I mean, some I know we want to move toward integrated healthcare in general, and I see some of the measures as moving us in that direction. To what extent can we participate in the selection of future measures? I was interested in the mention of 30 measures outside of the official PQRS list, and was curious to know more about those. So if you could speak to that, I would be really interested. Thank you.
So this is Dan again. Yeah, we encourage stakeholders to provide us input and suggest measures. There is a rather lengthy process that's been outlined in the legislation that we have to go through when we add measures to PQRS. Measure suggestions can be submitted, and we have a rolling submission period to CMS. Once they're received by us, they're evaluated by us. Assuming there's consensus, they go on this measures under consideration list, which goes before another group at HHS and then those measures that are deemed appropriate go before the National Quality Forum, where they are considered by outside folks for their suitability. And then after all that, if they pass all those hurdles, we can use them in the program. We don't absolutely have to have NQF sign-off, but certainly we prefer that, and there'd have to be a compelling reason why we wouldn't use it. One last quick thing. For folks that want to get measures more quickly into PQRS, or if their measure, or they have measures that they've developed themselves, we do, folks can submit measures and report measures to PQRS that are approved by CMS, but not submitted through the MUC process I just mentioned, if they're submitted through a QCDR that chooses to report them.
Thanks, that's very interesting. For a number of the providers on the call who may have never participated in PQRS before but are considering doing that, what happens if they don't do it right? There might be some, I know we think about, the last thing anyone wants to do is accidentally commit Medicare fraud. So how, to sort of allay that anxiety if possible, what happens?
Well, the fraud aspect, someone would have to blatantly try to commit fraud for this program, to really be in danger of that. We're not looking to, if somebody, reports the wrong quality data code, we're not looking to go arrest them and charge them, I think it's $10,000 per time or something, and put them in jail for 6 months. The people that we do, we are more sensitive to, however, are people that just blatantly make up data, to send in completely. So people that have had mistakes, and we have done some data checks with various reporting mechanisms, and we find that it's not always 100% match. Again, if it's an honest error, the provider didn't understand, they mistakenly reported the wrong code, we're not looking to make a statement about it, but more just to educate the provider. If someone said, that they were 100% on all their patients and they reported on every single patient, and we audited them and found that they didn't even do the quality action on one patient, that would be a bit more of a problem.
That's helpful, thank you. I guess one more question is, we're moving toward EHR adoption, and I think that PQRS right now is very accommodating of providers, as it would need to be, that do not have EHRs, that are in private practice, et cetera. Is that going to be it that way indefinitely? Are you going to be able to participate through claims reporting?
This is Molly again. So as we've mentioned in the past few years of our rulemaking, we have our information in the physician fee schedule rule. We have commented on how we would like to, at some point, move away from claims-based reporting. Again, as the agency as a whole is looking towards more electronic-based methods of getting data in, and really encouraging providers to adopt electronic health records. So it is something we are looking at for the future. With that being said, however, we do understand that for some specific specialties, claims-based reporting is what is mainly available to them. So we are weighing all of those options heavily. If and when we do completely eliminate claims-based reporting, we would provide ample notice, and we would provide a lot of information to providers on that. So I don't want anyone to be fearful that it will be going away, in the next month or two or anything like that. But, just when we do issue the physician fee schedule final rule and the proposed rule, take a look at it. And these are for future years as well. So hopefully that helps answer the question.
Interesting and helpful to know. I think I noticed last time I checked that we didn't have any behavioral health measures in the national quality domain of person and caregiver-centered experience and outcomes, which seems like something that behavioral health providers do naturally really well all the time. And I'm wondering about, how do we get a measure in there and get credit for behavioral health providers that are already doing what they do so well?
So this is Molly, and Dan definitely weigh in. So as Dan talked about earlier, there's a specific process to get additional quality measures in the program. So to get more measures in the program and in that specific quality domain, we would need to have new measures submitted to us, and then we have to go through the whole extensive process Dan talked about to have those measures in that specific domain. Additionally, as we mentioned, through the QCDR option, there is the availability to have measures that are outside of the PQRS measure set that could be within that domain. And Dan, I don't know if you want to add anything.
I think that summed it up, Molly. I mean, again, if we're talking about changing domains for existing measures, that's one thing that would actually have to be done in conjunction with the measure steward. If we're talking about new measures in particular domains, I think we kind of outlined the process at a high level earlier.
Great, thank you. Would you say that there's been more medical participation in the suggestion of measures than behavioral health participation, if that is something you have within your scope at all? I'm just curious where you've seen a lot of the measure suggestions coming from.
That's a little bit of a tricky question. We do have some part of HHS, SAMHSA and everything. There is a strong interest in behavioral health measures, because mental health issues affects, such a large percentage of our population, and particularly, the Medicare population. So there has been a pretty strong interest in, mental health measures.
Thanks. And that's, yeah. Are there other questions in the room? I know it's so valuable to have your time and to have you scheduled to answer our questions, so I don't want to waste any of it. I don't know what else I was thinking of. I guess this is a really basic question, and I feel like you answered it at the beginning of the presentation, and I just, for some reason, I'm still not clear on it. When an agency, and by that I mean in the state of Texas, licensed as a substance use provider agency, which may or may not have, Medicare physician, fee schedule clinicians in that practice, but if an LCSW happens to be providing services within a licensed residential substance use treatment facility or something, how does that work? Only applies to physicians in a facility that's licensed a certain way. Okay. Mandy answered it for me in the room. Do you guys agree with that? No, it's good. I can call her anytime.
I think, correct me if I'm wrong, I'm going to state it from my perspective, which is I think that a lot of the alignment of behavioral health psychiatrists used to utilize E&M codes and other things, or didn't used to use E&M coding to record their services. When that switch was made, behavioral health coding for physicians has switched to a much more mainstream kind of coding methodology so that it aligns better with the PQRS system and those kinds of things. So I think that, in general with parity and all that jazz, the psychiatry component of this is not as complex as it would have once been in a previous coding method structure.
Sorry, so this is Molly. I'm not a coding expert at all, so I can't really comment on whether or not that is accurate. Dan, I'm not sure if you can comment if that sounds correct to you or not.
Yeah, I'm not 100% sure I'm getting the intent of the question.
Okay, that's okay. We understand it was a complicated task.
I'm sorry.
No, it's not. It's fine. It's not you. Other questions? Okay, well, we are so appreciative. I think, PQRS, I acknowledge, is something that's a little hard to get our head around for anyone, and we do appreciate that you're trying to encourage us all to demonstrate our outcomes. and we appreciate your time and helping us figure out how to do that. And I think we're all going to get to better care one day together. And so we're really just grateful for the time you spent with us. And thanks for everyone's patience with the technical background noise at the beginning. And thank you so much for joining us.
Thank you, guys.
Well, thank you. Thank you very much for having us. Have a great rest of your night.
Thanks, you too. Bye.